I'm Brent O'Carrigan, so I'm a consultant medical oncologist out of Brooks in Cambridge, but also clinical lead for the GLH, so helping run this cell-free DNA pilot. The meeting is being recorded, so we will have that recording available for folks afterwards who couldn't join either this meeting or the meeting we held last Monday. And the slides will be available to send around as well. But more importantly, we also have all the documentation, so sites can receive the pack, which means the request forms and so on. Yeah, good afternoon all. So for those, some folks on the call have been a valued member from our previous pilots, phase 1 or phase 2, and some sites will be just joining us from phase 3 of this pilot. So then for context, this is really looking at a national NHS England genomics project to really advance the clinical use of a cell-free DNA blood draw in lung cancer. So at the moment, these are commercially available UCAS accredited assays for clinical use, but they're not yet commissioned by NHS England. And so really the whole purpose of this series of pilots is to test those already validated assays in clinical use. And there was a previous work with a previous pilot to look at the health economics of that. And so we hope that it will be shown to really improve patients' care and most critically be cost effective. So we're really getting people the care they require faster. So I've got a short slide deck on the pilot. And so as folks may have already seen before, one of the challenges in lung cancer care is getting molecular diagnostics from usable tissue, which can mean e-bus bronchoscopy or a CT biopsy of a lung lesion, which takes time to book the biopsy, tissue processing, and then molecular results are not as quick as we would like. So the red dots there are time from standard of care tissue testing to genomic results. And as we're all on the call well aware that your lung cancer care is now a stratified condition. So we do change therapies if people have a relevant molecular alteration. Whereas a blood draw, so the blue dots are the cell-free DNA test you can do at first presentation in clinic and get a meaningful molecular result back much sooner. And then where relevant, start therapy sooner for those patients. So this pilot will be expanding to the next phase, phase 3. It looks and feels very similar to the previous pilot, phase 2, that most sites on the call were on actually. At the moment, the actual samples are being processed and run by 2 GLHs, so North Thames in London, which is the Royal Marsden, and Great Ormond Street will run our samples from East GLH, our region, plus a few others on the call as well. And phase 3 is designed to be, just pop on mute if you're not speaking so other folks can think of that. So phase 3 of this pilot is designed to look and feel like this test will be delivered through clinical standard of care. So there's no requirement for data collection, which was a concern for some sites with the previous pilot. Samples are still collected at site by your clinical teams and then sent via Royal Mail safe boxes to the processing GLH, which for us remains North Thames and the Royal Marsden in London. Pilot is live and active now. Over time, it's envisaged that other GLHs may take on and start to process the samples themselves and will update when required. But for the moment and for the foreseeable, we're still sending kits and samples to North Thames. So nationally, I've actually provided kind of funding to process 10,000 tests, for lung cancer patients, and they're split by region, approximately by population, by placental. But I really wouldn't worry about the numbers precisely. It's designed to really be increasing activity, increasing use, and again, we hope that there'll be a clear line of sight that this test is then commissioned by NHS England for routine care. Now, the eligibility criteria is not changed. So again, this really refers to folks who've got radiologically suspected lung cancer at stage 3 or stage 4, whom if a mutation were to be found, they'd be suitable for systemic therapy. So that, for example, that really means if there's an activating EGFR mutation, they'd be suitable for anti-EGFR therapy as well. People can also have a blood draw sent if they have a diagnosis of lung cancer, but there was insufficient tissue or a QC failed to get molecular on that result. So you commonly might have a very small FNA from a lymph node somewhere. You might have an HME, a diagnosis of lung cancer, but not sufficient for molecular. So you can do a blood draw again if you've had moleculars not go through before. But I would emphasize, this is not a clinical trial. These are not ironclad criteria. I'd suggest people look to those, but people will not be audited on this. That this is designed to be quite a permissive and inclusive patient population. People do not require a consent form for the blood draw. The blood draw is a secondary care diagnostic test like you'd have at any other secondary care centre, and does not require a specific consent form to either have the test or take part. It's really providing a currently available commercial assay at no cost to patients in the NHS. Is the current kind of purpose and pathway. So to get your sites active, so a key difference from the previous pilot phases were that whereas before the kits were sent out by our team directly, so they were sent to your local GLH and then distributed, now sites can request kits, so BCK's blood collection kits from the Marsden directly. The contact email is there, so marsden360@rmh.nhs.uk, and there's a form you complete. So we'll email the forms to your sites. I think we already have actually, and there's a snapshot there on the right of what goes on the form. It's just the hospital, their delivery address, and how many kits you would like in batches of 10, so 10, 20, 30. And we'd ask sites to request the number of kits that they're going to use. So you're welcome to keep a few more in stock. It's not mapped precisely, but just avoiding you expect to use over a period of time. You would then send that request form to that email address, and they will send the kits directly to your site for their clinical use with patients. We've also sent to most sites, or the Marsden can share, the test request forms, instructions for use, which I'll go through in a moment as well, labels for the tubes, and information sheet for the patients. And to clarify, that's not a consent form, it's more just information around what cell-free DNA means and why it's useful for patients, and a bit about how it's done. It's not, there's no requirement for a written consent to have the test drawn. And so again, folks will I think most of you be aware that you would actually send 2 blood tubes, so 2 the brand name is they're Streck blood tubes, fill the tube to the line, and then mixed by inversion before them, and they're labelled and return the packaging you've got here over the page. And these are room temperature samples. These do not require, and actually are not meant to be refrigerated or frozen. Ambient or room temperature is preferred. And then for the shipping, so the completed test request form plus the labelled blood tubes go into the biohazard bag, then to the Royal Mail safe boxes. These are all provided to sites as part of the blood collection kit. And then you check everything is all right, then they're returned with the included prepaid postage label via Royal Mail down to the Royal Marsden, and they're typically received the next day, so they're prepaid priority postage. The blood test is stable really for a day or 2, so they'll be processed by the lab on the next working day. So just a short overview of the results to date. So this is from a large part of the actual guided assay that underlies the technology. And so as we'd expect on the call, most folks here have either EG5, but of the mutations found, most are either activated EG5 mutations or KRAS G12C. I won't get into details of drug like cancer therapy, but that's another commonly observed mutation, or MET mutations, which are also eligible for other targeted molecular therapies. So that's for folks who do have a mutation disclosed on the blood draw to date. Let's also look at the whole pathway. So although a complex slide really walks through that once your site is active, actually I think most folks on the call are already active as a site. If you not, reach out to myself from Sobia, request the blood collection kits to be sent to your site directly, and then once you've sent the kits, then the packages are sent, the kits are returned to your site from the central team, and then once you've clicked the sample, you approach a patient, you then return the filled blood tubes with the forms to the Royal Marsden, and then they will then at the moment email back to you that result. And so on your request form, you'll specify an email that should be returned to, and they'll return results to that email address. Folks are welcome to use a personal provider if there's a particular clinician or even a specialist, or also it can be an inbox address. So it's commonly using an inbox for lung cancer nurses or nurse specialists, for your trust. That's completely fine. We will encourage a copy to your local Genomic Laboratory Hub, which for now is myself. So we're going to put my email on the form. I'll share my email with you in a moment. We will be designing an inbox for these, but that's not live today. But that's not really required. Patients that require for their clinical care can have tests sent now, and the results returned to your treating teams. And you can specify that in a couple of emails on the form. It can be a particular person or perhaps a consultant, and the nurse can the lung cancer inbox, for example. So common queries. So ideally fill up the tubes to the line. It's not essential, to be fair, but I wouldn't suggest you underfill the tubes. If there's really been a permanent blood draw, you can still send the tubes, but to the line is preferred. If sent on a Friday, that's okay. So sent on a Friday, they'll still be processed on the Monday. So there's not a day that you can't send samples. They'll be processed all the time. I guess prioritising weekdays is preferred, but they'll be processed whenever they're received, preferably within 1 or 2 working days. Now, that same email address, so marsden360@rmh.nh.uk, is also your contact number for queries. So if you've not received the results, then contact that address for the first few escalations. Actually, to be fair, they've been pretty sharp. So most folks have them back within 14 days anyway, often 10 days. And that's who you'd address queries to for lab side things. So if it's about a result, that's better off to the lab directly rather than myself or the project team as well. And for other indications, over time, possibly. At the moment, because the most clinical data is for lung cancer, that's where the pilot's focusing, and this is still a lung cancer assay at the moment. But folks may be aware there is evidence this could be sort of other tumour types that's not part of the pilot, but may be for future pilots as well. So the final slide is on relevant email addresses. So Dr. Sobia Hamid works with me. She leads the program of the cell-free DNA assays. I'm the clinical lead. My email is on the slide there. So b.o'carrigan@nhs.net. And Collins Bench, who's our strategy lead, is also welcome to be contacted. You've got the email address for the central laboratory team, and there's more information available online. It's quite a long website, but if you just Google East Genomics ctDNA, you'll find the same landing page. Information there for clinicians and also for patients and their families.